morning we're fortunate to have two very highly qualified presenters from the Calvert County Behavioral Health section of the Maryland Department of Health. Casey Vendetti and Veronica Rivers are both licensed master social workers and have a great deal of knowledge and experience that they want to share with us. They're going to talk a little bit about the pandemic's impact on people's mental health. You know, we've all experienced this on some level, but it's really created barriers for those who are already suffering and those particularly that suffer from substance use disorders and other mental illness. And they're going to also provide some resources for all of us to have and to share with our friends and family and loved ones. So welcome to our presentation, and I will hand it off to Veronica and Casey.
Okay, so I guess we'll go ahead and get started. My name is Casey. As they mentioned, we're with the Calvert Behavioral Health, which is a division of the Star Health Department. To give a little bit more description about me is that I'm a counselor. I primarily work within our detention center, and I also do some mental health work also in our clinics. And Veronica over here, she works primarily, she works in our clinics as well, but also works primarily with our psychogeriatric population. So people that are like around like age 60 and older. So that's a little bit about us, and I guess we can go ahead and get started.
Okay.
All right, so just some things that we're going to talk about today. We're obviously going to talk about the pandemic, but something that the pandemic did very, very well was let us know about the problems that already existed. The pandemic exacerbated issues that already existed in our community, and we're going to touch on what those issues were before the pandemic and also touch on what they are now after or during the pandemic, those being substance use, mental health, like anxiety, depression, domestic violence. And we're also at the end, we're going to kind of talk a little bit about some coping skills, some things to kind of do to make ourselves feel better. All right, so first we're going to start off with some substance use basics. So first off, who is more likely to be affected by addiction? It's unfortunate, but it is true. Addiction touches all populations, all races, genders, ages, economic status, and even though that substance use hits all these different types of populations, the cases are unique in terms of how the addiction starts and then how it progresses, and also what that recovery looks like. So how does addiction affect our lives? We're going to talk about this a couple different times throughout this little presentation, but if you could boil down your life, your functioning into 3 different aspects, you would boil it down to one, your personal relationships, so like your ability to spend time and engage with family members and friends. Another one would be your ability to contribute to your community, so your ability to go to work, your ability to go to school, and how you function in that realm of your life. And the last one would just be personal hygiene. So this can be something as basic as being able to shower every day, brush your teeth, wash your hair, and also things like self-care is going to fall into like that personal hygiene as well. Something kind of going on about the basics of substance use would be how substance use changes your brain and how your brain functions. One of the things that we have listed here is traumatic brain injuries. We're going to go a little bit more into overdoses, but one of the things that happens when you do have an overdose is that oxygen is not able to get to your brain, and that is in itself a traumatic brain injury. Also, some things that substance use does, your brain is constantly changing and adapting based off of what you're doing. So if you are doing positive things, your brain is going to adapt to those things. And also if you're doing some things that maybe aren't so great for you, like substance use, your brain's going to kind of be manipulated and changed based on that activity as well. So here we're going to talk about some of just the statistics. These are specific to Calvert County. These are specific to 2020. I mean, you all can kind of see what the numbers are here. It looks like overdose rates were higher among men, were higher among Caucasians. And at the bottom here, you can kind of see how like we've boiled it down. So we have our total number of overdoses being 132. So that averages about 2 overdoses a week. I'm not saying that we've had exactly 2 overdoses a week. This is just kind of an average number to kind of give you an idea as to what that number looks like from day to day and week to week. And then our fatalities, we had 23. And again, these are numbers specific to Calvert County. So if you look at other counties, they're going to look different. And if you look at the state of Maryland, they're also going to look different. I think it's important to kind of see what's happening with our county. I think that the larger number, that more like global aspect, is often looked into, and those numbers are really big and kind of hard to wrap our head around. So here's a little bit more about what's just happening in Calvert. So we can get a little bit more in depth as to what's happening within our county and where it's happening. So you can see here that most of our overdoses were opiate or heroin related. And you can kind of see some of the other things. Our second highest was prescription medications. Now, that could really be anything, but what I see mostly is things like cough syrup and things along those lines. And then you get to see it kind of broken down by location. Just kind of at a glance, we're all pretty much in like the teen like area, except for Lesby being our highest, and Brooms Island being our lowest. So this is a little snapshot of 2021. This only goes from January to February. This information is all on the Calvert County Sheriff's website. And the reason why this window isn't up to date, up to as of the 14th of April, is because they kind of broke this down into areas as well and got a little bit more information about these overdoses. So this is the information I'm going to present. As you can see, we're still about like around 2 overdoses each week, and we've had 3 fatalities this year. Something else that we have numbers on this go around is how many times naloxone was administered to someone that was in an active overdose. I'm not sure what everyone's understanding of naloxone is, so I'll go into it a little bit. Naloxone is also called Narcan, and essentially what it does is it is a little thing. It's about so big, and it is administered through your nose like any other like allergy medication. You kind of press the bottom, and this like liquid gets sprayed up into your nasal cavity. And basically, what happens in an overdose is that opiates are depressive, and it changes your body's ability to breathe or its ability to want to breathe. It slows everything down. And what the Narcan does is it kind of counteracts that. It gives your body a little bit of a boost to keep you breathing, keep you going while your body's kind of processing all of the substances that you had put in it or that these individuals had ingested. Narcan, you can get Narcan at any of our health department locations. We're going to talk about the locations at the end. We do have Narcan trainings. I'm not sure exactly when they are, especially given the COVID pandemic, how we have kind of adapted those trainings. But if it's something that you're interested in, it's definitely something we can get more information about too. All right, so now we're going to get a little bit into what substance use looks like. It doesn't always look like how we see it, like on shows. A big show is like Intervention. They showed very extreme cases, and although those situations do happen, they aren't necessarily a good picture of what substance looks like across the board. So I kind of want to go a little bit into that, talking a little bit about functional substance use. I think we've all are more likely have heard the term the functional alcoholic. That you can function on other substances outside of alcohol, but the concept is the same. Basically, you're doing the bare minimum of what you need to do in a day. You're getting up, you're going to work, and you're coming home and you're indulging in whatever substance that you're using. I've seen people do this with alcohol. I've seen people do this with opiates and heroin. People can function on these substances, and we'll go a little bit more into that as we kind of go on through this. Something else that you're going to see in substance use is the mood changes. From the outside looking in, you might see that someone's might be just having a bad day. They're kind of irritable and their emotions kind of go up and low and are a little bit all over the place. So you might think, oh, there's something wrong with them. But for certain individuals that are using substances, their mood is directly related to their substance. If they're able to get it, if the substance gave them the high that they were looking for, And so you're going to see a lot of mood going up and down. Another thing is that there is no self-care among people that are dependent on substances, on any type of drug that they're on. You'll see that uh, people, when they experience stress or even when they experience anything, the only thing they know how to do is use these substances. They don't know other ways to calm down. They don't know other ways to solve problems. All they know is that if life is stressful, I'm going to take the substance and that'll make it better, even if it's just for the moment, even if it's just for a couple hours or the rest of that day. Something else that you're going to see, we kind of go, this is that like those three aspects, right? So the first one, that like no self-care, that's like your personal hygiene, you're not functioning there. This one, we go into that aspect of functioning in your relationships, friends and family. So if you're, are you not talking to your friends and family? Are you kind of isolating? Are you being alone? Is it because of you're hiding your substance use? Is there a little bit of shame or guilt based off of what you're doing every day? Something else that we also see is that people will surround themselves with people with similar behaviors. Sometimes it means they change their friend group or they change their like normal like their work group as well to so they're around people that are also doing that substance. And what this does is it normalizes that behavior. It's not, I'm doing something abnormal, everyone around me is doing this substance. It's not a big deal. It happens all the time. Everyone does this. And it also kind of goes into the next thing here about rationalizing this behavior. I'm not an addict because I don't. Something that I've seen personally, I've kind of coined the term like a drunk mascot. Basically, people will keep certain friends around that their abuse is more significant or maybe more known or more easily targeted or seen. And they use that as, well, at least I'm not as bad as so and so. This person gets up and they need to drink because they shake. I don't do that. And what that does is it means that I don't have a problem and I don't need to look at myself. I don't need to think, oh, well, I get up and I go to work and I'm hungover, but at least I don't shake. So you can kind of see what happens throughout this like cycle and without and how your thought process changes and you're rationalizing your behavior. And that's kind of one of the ways that people continue on and where you kind of find that question, like, how did you let it get so bad? This is one of the ways that you kind of manipulate your own thoughts so it can eventually get to that height or that level of dependence. Okay, so this is my ultimate favorite slide. Why I like it so much is I think it really kind of describes what happens when someone is on a substance, when someone is dependent on a substance, and it kind of goes through how it occurs through time. So the first thing that you're going to see here is that we do have a baseline. So this is just your normal day-to-day, what your brain has given you. This is how we function at a base level here. And you can kind of see we go up and we go down in this like little like with this arrow that says normal. So what our brains will naturally give us highs and will naturally give us lows. We have good days and we have bad days. Mental health is fluid. It goes a little up, a little down, kind of depending on what the situation is. All of that is normal. And then when we kind of go a little bit over and we see abuse, what happens is that this is when we use substances. Substances give us a high that our brains don't give us, not at that level. So if you are going and using something, you get that euphoric state. Maybe you've heard of there was no high like my first high, and this is kind of why that happens. That first high is the highest you're ever going to get. And with every high, you have an equal low. So if you go out and you're drinking, you might feel really good while you're drinking, but that low might be that you're either vomiting or you're finding yourself really emotional or just not really feeling good. So like I said, every high has an equal low. And as time goes on, you'll find that the high that you get is not as high as it once was, but your low is still equal. And as that time kind of goes on, and as we kind of see abuse turn into a dependence, is that now we're using not to get high, but just to get to that functional level, just to get to that baseline. This is also, again, where you're going to see that like functional substance use. I need to use more and more substances just to feel like everybody else, just to feel content, just to be able to get out of bed, that day. So yeah, that's kind of your difference between your abuse and your dependence. And it happens through time. The more and more we use, the more and more likely that we're going to become less of an abuser and more dependent on that substance. Okay, so this we're going to go into risks versus the addiction in itself. Risk, we're all at risk. We can all kind of play or do certain things with substances and might fall into some aspects of being at risk for addiction. I don't want everyone to kind of go out and diagnose themselves with an addiction versus not an addiction. This is just to kind of give you a little bit of an idea of some things that you might want to look into, you might want to think about, um, and just kind of evaluate it on your own terms. Was that something that's I want to do? Was that something that I way to live my life? Or am I kind of putting myself at risk for something a little deeper if I continue on? So some things to think about is like these self-destruct. One is being those self-destructive behaviors. If you're going out and you're drinking, are you drinking so much that you're putting yourself at risk? Are you getting in the car? Are you getting in the car and then inviting your friends in the car? Are you guys putting yourself at risk, one, to get hurt, but also to get thrown into some legal charges? Obviously, we shouldn't get into the car and while we're drinking, it could hurt somebody. But also a big deterrent is these charges that you're going to get. I promise you, your first DUI is going to cost you more money than you have. Don't drink and drive, kids. I promise it never will end well. Another thing that we kind of go through is those mild physical injuries. Those like I got drunk and I ended up breaking my hand, or I got drunk and I ended up hurting my head. How often are those things happening? And how much alcohol did you consume? And then you don't really care about your physical body so much that you're causing pain to it. Another thing being emotional distress are like these conflicts. So at the end of a night, you're out drinking, you're out with your friends. How's that night ending? Are you kind of satisfied? Okay. Are you able to go home, feel all right? Or are you emotional? Are you crying? Are you getting into fights with people that you don't normally fight with? Are you having big arguments in public? Things like that. So again, we're kind of going back to our highs and what do our lows look like. So that means if your low is really low, that to me tells me that your high must have also been particularly high. So what you're looking at in risk here are those extremes in behaviors. What are the extreme things that you were doing that's directly related to whatever substances that you were doing? And then moving on into addiction, the difference there is that there's consistent dysfunction in some level in one of those three aspects of functioning. So there is no self-care. There is nothing that you are doing to take care of yourself on any level. Is your body dependent? Do you need to drink, or do you need to use something to get out of bed to feel motivated? Are you seeing that your body's having like physical reactions? Are you withdrawing? Are you shaking? Are you getting like night sweats, headaches, stomach aches because you don't have the substance? Another one is, are you unable to maintain your relationships? If you are finding that everyone that loves you and was once a part of your life can't handle being around you because of the substances that you're doing, because you're either always high or always trying to get high, that's a warning sign. That's definitely saying that there's something going on here that should be reevaluated. Right. This here is a dual diagnosis. Dual diagnosis is basically saying that you have both a substance use diagnosis as well as a mental health diagnosis. This is extremely common among the population that I work with over in the detention center. Really, what I have found personally is that substance use is just a really, really bad Band-Aid for either untreated mental health issues, trauma histories, or even grief. What I've kind of seen as a pattern is that when people experience things that are distressing, emotionally distressing, and we don't think that we have the skills, or we don't think that we can handle or even just trust ourselves to do and face our problems. We can see this largely among men, but also with women, where we are avoiding our issues. I had a really bad thing happen to me and I don't want to think about it. I'm just going to go to work. I'm just going to go to school. I'm going to function like it didn't happen. And what ends up happening with that is that your brain and life has a funny way of creeping back up with you if you don't face that issue. And we see this really a lot in substance use. And we spend a lot of time going back into someone's life to see what may be triggered or what maybe started this dysfunction. And then now we're here with dealing with the substance use issue, and also now dealing with the substance use dependence. So what happens when we don't face our problems is that they creep up later. And when they creep up later, now we don't even know why we're upset. Now we don't even know why we're angry, or we're lashing out at people that we're not even really angry with. And you can't quite pinpoint why. And it's because when we had these traumatic events, when we had maybe a death in the family and we experienced grief, we did everything in our power to say, nope, I can't handle that. I don't want to handle that. I'm not going to. And as time goes on, life finds a way of creeping back in, and now we are dysfunctioning and we don't really know why. And that's a really big cornerstone of what is dual diagnosis. We had a problem, we avoided it, and now we've solved it with substance use. And so we often see those two things go hand in hand.
So now we're getting to mental health. Mental health and substance abuse, kind of like what Casey was saying, is interconnected. It gets to a point where it'll feed each other. But just talking about mental health here, stress versus anxiety. So everybody experiences stress. It's a perfectly normal, human condition. There's, mental and physical symptoms. There's irritability, anger, muscle pain, digestive problems, trouble sleeping. Now, the difference between stress and anxiety is persistent. It doesn't go away after the stressor has gone away. And so here we have high functioning anxiety. So I think a lot of students can relate to high functioning anxiety. It's where you're under a lot of stress, like in school, like you have a lot of homework to do, you got to make classes, you're staying up till 2 o'clock in the morning to finish a presentation, those kind of things. So an anxiety disorder, it differs from short-term feelings of anxiety or high functioning anxiety and how long it lasts. So anxiety, typically, it can persist for months and it negatively affects your mood and functioning. There's some disorders, and the example I used here was, and I can't pronounce it, sorry, agoraphobia. And so it's the fear of public or open spaces. And it makes, a person avoid enjoyable activities or makes it difficult, to keep a job. And I think I use that as an example because I, feel that, with COVID, I think it caused a lot of, stress and anxiety about going out in the public. So these are some memes that I found related to anxiety that I thought you all might like. Getting into anxiety disorders, they're common. 19% of Americans over the age of 18 has had an anxiety disorder. 31% of Americans will experience an anxiety disorder in their lifetime. The most common one it's called generalized anxiety disorder. And for a clinician to diagnose it, they're going to look at excessive, hard to control worry that occurs for most days over the course of 6 months. The worry may jump from topic to topic, and it's also accompanied by physical symptoms of anxiety. So when I'm assessing a client, I'm asking, do you have any digestive problems? Do you have trouble sleeping? Even actually, some people will break out in like eczema or a rash as a result of anxiety. So then another type of an anxiety disorder is panic disorder, which is when for seemingly no reason at all, they'll be marked by a sudden attack of anxiety. They'll, excessive sweating, they may get dizzy, they may feel like they can't breathe. And it can also manifest in the form of phobias, like a fear of flying, social anxiety, which is the pervasive fear of social situations. The treatment for anxiety, it's usually a combination of treatments. So that includes psychotherapy, medication, or both. And a lot of people also, they start practicing probably more self-care in addition to those things than they did before. They might do some holistic things, acupuncture, essential oils, meditation, those kind of things. Now, there's a little bit more of an extreme therapy called exposure therapy. So you might have seen this where maybe someone that's afraid of spiders, they give them a spider to hold or something. And it's a way to kind of, break their cycle of fear around that trigger. So this is where I was gonna let the audience here kind of maybe talk about ways that they've seen how COVID has contributed to depression. And we can kind of talk about that a bit. I can't see the chat room, so if the moderator sees anything pop up.
Veronica?
Yeah.
There does not seem to be any questions or comments in the chat.
Okay, that's fine. We'll keep going. Thank you.
Mm-hmm.
All right. So depression, that's another pretty common mental illness that we're seeing a lot of. It's also known as major depressive disorder. It's a serious medical illness that affects how you feel and the way you think and how you might act. So it affects an estimated 1 in 15 adults, about 6% of the population in any given year, and 1 in 6 people will experience depression at some point in their life. So it can occur at any time, but it usually, like a lot of mental illnesses, it first appears during the late teens or mid-20s. Women are more likely than men to experience depression, and some studies show that 1 in 3 of women will experience a major depressive episode in their lifetime. There's a high degree of heritability, so it runs in families. It's about 40%, especially if it's first-degree relatives, so parents, children, and siblings. So the symptoms, they can last, up at least 2 weeks, and it's marked by a change in your previous level of functioning. And let's see. Now, the important thing here is sometimes depression can be a symptom of something else. So a lot of times when I have clients that feel like they're depressed, I also want them to get medically cleared. So a lot of common, medical issues that cause depression, they're, thyroid problems, it could be vitamin deficiencies. So it's important to rule out medical issues. So here's some symptoms of depression. So obviously, feeling sad or having a depressed mood. And you're also going to want to notice if there's a loss of interest in things they once enjoyed. So maybe, they were taking yoga regularly, or they were maybe hanging out with their friends regularly, and now they're not so much. It can be a change in appetite. It could be, losing your appetite, not really eating a lot, or it could, it could be you're eating more because you're maybe trying to self-soothe. So you're also going to look at if there's trouble sleeping or if you're sleeping too much. And then there's a loss of energy or increased fatigue. So maybe they're just like, they're tired all the time. Let's see. Oh, okay. So so it says an increase in purposeless physical activity, which is like fidgeting, pacing, maybe they're walking slower, talking slower, and it's something that's observable by others. You're gonna look for feelings of worthless or guilty for things, you don't really need to feel guilty about. I've seen, memes and heard from a lot of people that are like, they're laying in bed and they're thinking about something that happened like 10 years ago. And so that, kind of goes into difficulty, thinking or concentrating or making decisions. And then of course there's thoughts of death or suicide. And the thing with suicide is if you suspect someone might be suicidal, what you want to do is you come right out and ask them. You don't dance around it. You don't, slowly ease into it. You go, are you feeling suicidal? Are you planning on killing yourself? Do you have a plan? And studies have found that most people will answer truthfully. They'll be like, if you put them on the spot, they'll be like, yes. Or they'll be like, oh my God, no, I would never do that. So here I put, if anyone wanted to contribute, what might be other signs or symptoms.
There are a few statements. One from earlier from Jacqueline saying, leaving a place because their CDC social distancing is not effective. And someone went on to say that I know my depression can worsen during the pandemic due to no change in my daily life.
Yeah. Anytime when routines get disrupted, that can cause, anxiety, depression, or both, it's definitely stressful. And what was the first statement? I didn't really hear it.
The first statement was made earlier. It says leaving a place because their CDC social distancing is not effective.
Oh yeah, that too, for sure. For sure. Okay.
We also have a statement saying that, yes, the monotony from day to day worsens and creates that for me as well.
Definitely.
And then someone else added, same here. I started having daily panic attacks and depressive episodes early on during the pandemic, but I have also developed healthy habits and sought professional help to combat it.
Yeah, we're gonna kind of get into that later about, some pros of COVID. Not that there are a lot, but kind of like what Casey said earlier, all these things were happening and COVID really put like a spotlight on a lot of these things and where, areas, as a society and a community that we need to work on. For sure.
Also, just to add on, good for you for going out and getting help, and also good for you for talking about it. Even putting it out there, there's still a lot of stigma around it, and it still takes a lot of courage to be able to say, you know what, I was having an issue, and you know what, I did need to seek a little help for it. So I'm happy that you did that, and I'm really happy that you shared it. So thank you for that.
Yeah, thank you. I was gonna say too, I know in the beginning of the pandemic, I had to limit how much news I watched because it was, it used to be when you watch the news, it came on TV twice a day. You'd read the newspaper in the morning, you'd watch the evening news, but now it's all the time with social media and, things like that. So I had to limit it myself. So I think we were all feeling, some anxiety for sure. So factors of depression, I'm just going to minimize this so we can see it.
Veronica, we have one more.
Oh, sure.
Actually, two more.
Sorry.
Oh, no worries. We have a statement with the tendency to isolate anyway when it comes to mental illness. It is easier to slip into those depressive or anxious episodes. And we also have a statement from the student who shared earlier. Thank you. And yes, I definitely limited my time on social media to help.
Awesome. Yeah. So are we good?
Yes, thank you.
No, you're good. And if anyone, has, anything they want to say, there's going to be a couple other times where we stop and chat. So, all right. So factors of depression. There are several factors, but studies have kind of narrowed it down into these things. So one is biochemistry. It's literally chemicals in your brain or lack thereof can contribute to symptoms of depression. There's genetics, like I said earlier, it runs in families. And one little fact here that I wanted to add was if one identical twin has depression, the other has a 70% chance of also having that illness. So, and I'm sure there are other factors of that too, but it's definitely genetic. Personality. So people with low self-esteem, maybe they're easily overwhelmed by stress. Maybe they're, pessimistic. They're more likely to experience depression. And of course, the personality, there are other things that could, factor into that, things that lead to low self-esteem. And that kind of, goes into the environmental factors. So if you're exposed to violence, bullying, neglect, abuse, poverty, you're more vulnerable to depression. Treatment for depression. So about 80 to 90% of people with depression eventually respond well to treatment. So there is treatment for it. And it's one of the most treatable mental disorders out there. And like most mental illnesses, it's treatable because of medication. So we've kind of talked about it earlier about the biochemistry. Medication, what it does is it will balance out maybe some things going on, some chemicals in your brain to help ease depressive symptoms and depression. So they're not sedatives, they're not uppers or tranquilizers, and they're not habit forming. So I think it's worth noting what makes something addictive is when you start to need more and more of it, or you're getting, some kind of effect of it. So most like antidepressant medications, you might need to adjust the dosage, but typically, if you take it, once or twice a day, you're not going to take more of it to like feel better. It's you'll go to your doctor and you'll be like, hey, I'm taking it twice a day and it's not really working for me. And so then they might have to adjust it or change it altogether. And they have no stimulating effect on people not experiencing depression. So let's see. The thing though, also with antidepressant medication is it can take up to 2 weeks for it to build up in your system. And then of course, some medications can take up to 3 months. And if they don't feel any improvement after several weeks, that's where they can alter it or change it. And now in some situations with like persistent depression, where maybe you're getting medication, maybe you're in therapy and you still are experiencing symptoms that you just can't kick, they might add an antipsychotic medication. And it can be kind of a mechanism that makes an antidepressant work better. So I'm not a chemist or a psychiatrist, but that's generally how that works. And it's important, obviously, to let your doctor know if you're experiencing any side effects or if your medication's not working. And the psychiatrist will usually recommend that patients continue to take medication for 6 or more months. And then there's longer term maintenance, and that's to help decrease the risk of you slipping into depression in the future, especially for people high risk. Psychotherapy or talk therapy it can be great, to use alone for mild depression. But for, like I said earlier, for moderate or severe depression, they will pair it with medication. CBT has been effective for most people, and it's a form of therapy that's focused on the problem solving in the present. So they look at like ways to help you find solutions, to things that are going on right now. It can help with things called cognitive distortions and negative thinking. And it may involve the individual. There's also family and couples therapy to help address maybe issues with close relationships. And then there's group therapy, which they oftentimes will bring people with some similar illnesses together in a supportive environment, and kind of that community is therapeutic for people as well. So the length of treatment, it's it could take a few weeks, or longer. I think probably our average groups at Calvert are about 6 to 12 weeks, depending on what's going on. And a lot of people notice improvement on average between 10 to 15 sessions. So that could be individual or group sessions. And I just added this link at the bottom, and it's called Psychology Today. And it's a great resource if you are looking for a therapist or a psychiatrist in your area that accepts your insurance. So it's called psychologytoday.com. So I included this, as a treatment. It's electroconvulsive therapy. It's also, known as electroshock therapy. And this is for our, really extreme cases of, depression, anxiety, or both. And they're not responding well to treatment. And it's, let's see, a patient will typically receive the treatment 2 to 3 times a week for a total of 6 to 12 treatments. And it's managed by a medical team, including a psychiatrist, an anesthesiologist, and a nurse or physician assistant. It's been used in practice since the 1940s, and research has shown that it's led to major improvements in its effectiveness. But again, it's a last resort treatment. And I just listed some hospitals that do ECT, and there's many other smaller ones in Maryland, but these are kind of the big ones. Probably a lot of you have heard. Shepherd Pratt is a mental health hospital up near or around the Baltimore area. Same with Johns Hopkins, and then behavioral health at Midtown. So grief. I wanted to do a slide on grief because obviously with the pandemic, we've lost a lot of people, through, either COVID or through, depression and or substance use. And so I wanted, to put in here that grief is totally natural. It's not even, defined as an illness in our, in our DSM. So it's totally normal, and it's a response to, ending of relationships, ending of jobs, ending of, when you lose someone. And it's the grieving process is unique to each individual, and it shares similar symptoms of depression. So a lot of times you'll see in grief, you'll have the painful feelings will come in waves, and they're sometimes they're intermixed with positive memories of the deceased. So a lot of you might have experienced where, maybe you think, of a happy memory of a loved one, and then you start to get upset because, you miss that person. So that's natural. Now, where that differs in depression is where your mood or interests are, decreased. Maybe you're indifferent, to those kind of things. So in grief, also your self-esteem is usually maintained, whereas depression, you'll have more feelings of like worthlessness or hopelessness and some self-loathing. And then in grief, thoughts of death may surface, wanting to be with your loved one. But in major depression, it's more on wanting to end your life because feelings of worthlessness or not being able to cope with the pain of depression. And then grief and depression, like I said, can coexist. And I think with COVID too, the grieving process is different and more challenging for a lot of people, because I know there were a lot of individuals who, they had a loved one in the hospital and they couldn't go out and see them. And, maybe they had funerals, but you couldn't have, either your whole family there, or you couldn't have the service altogether. So I think, during these times, it's especially challenging. So I added time for a little break. So I don't know if we wanted to take like a 10-minute break, if that's okay.
Hi. I think we could maybe just go zoom on through and just see if any of our participants want to ask some questions. Sure. And kind of do a little back and forth. It looks like we may have a couple more comments. Do our moderators want to see if there's anything there that we might use as a talking point?
Of course, let's do it.
There's a question that asks, what is some advice you have for someone who's reluctant to get professional help, such as a therapist, for anxiety and or depression?
So I can speak a little bit to this. I often talk with clients that are a little bit reluctant about doing treatment. And if you're talking to someone, granted, it's going to be different based on the situation, and you obviously know this person better than I do. But just a good trick or something to keep in the back of your mind is that folks really want to do things independently. No one wants to think that they can't handle certain stuff or that they are unable to do certain things. So keep that autonomy. Allow them to know that you are strong, you are independent, you can do these things on your own. And then kind of finish it with why. Why you don't have to do it on your own. Why do you need to do this on your own when you have people that are trained to help you? You have people that have dedicated their lives specifically to help folks cope with life stressors, cope with whatever it is that you might have going on. So hopefully that's helpful. Again, I don't really know the specifics of the situation, but that's normally my cornerstone advice. You kind of build people up and then allow them to really think about what their options are and what they'd be willing to do. Something to avoid is letting someone know how bad things are. If you tell someone that you're terrible at this, that, and other, all these things going wrong in your life, and you don't balance it with what they have going for them, it can become a little bit more harmful than helpful.
Yeah, I would say too, I think a lot of people are resistant to seeking treatment because of the stigma around it. And what I do often is I compare it to other medical illnesses. And I do that because I think, well, one, I think there's a lot of stigma with mental illness because the symptoms are behaviors. And, I tell people, you wouldn't tell, someone that's, diabetic, that they have to treat themselves. You want to tell someone, with a number of different medical issues, not to go see a doctor, just meditate, you would want them to seek help in some form or the other. So that's, one angle I take sometimes, depending on the client and kind of where they're at. I don't pressure anyone to take, medication, but I let them know, again, a lot of mental illnesses are treatable because of medication. Before with, more extreme cases, maybe with bipolar or schizophrenia, they didn't know what to do with them. And so you got people out of asylums with medication. So they're powerful and they're helpful. But, again, for someone maybe with more mild depression, I meet them where they're at. They don't want to take medication, I get that. But, again, it's, therapists, we're helping them, kind of organize their thoughts or process maybe some tough emotions or things that happen to them. So they're doing it. We're just kind of assisting them. We're not doing, the work for them. We're just kind of there as a support and to help. So
one other thing I'll just mention, and I learned this from an event that I went to yesterday on Tuesday. We did another event and it focused on mental health, and a couple of the psychologists that were in that session said that due to the pandemic, they had started seeing patients using telehealth instead of coming into the office. And at first they weren't sure, because it's telehealth and you're, trying to connect with your patient. But they actually said that some good things had come out of that. And one of them was for people who are reluctant to be seen and to go into an office and to be face to face and share, the problems that they're having, that there's more comfort in doing that behind the screen, and you're in your own home and you're able to connect with your therapist or your psychologist or your psychiatrist, through the screen. And she, one of the panelists said that she thought that would continue because they were, some people were just so much more comfortable doing that it kind of opened the door to people who wouldn't necessarily feel comfortable maybe walking into an office.
Yeah, I agree. And that's, I think, kind of on the lines of meeting someone where they're at. You know, they don't want to come into an office, but okay, do you want to do like a telephone session, a telehealth? And then maybe as they grow more comfortable, then they might be more comfortable. And as things open up, they might be more comfortable coming in. So yeah, that's awesome. I think that's another thing that will stick around as well.
We also have a statement. I started therapy over the phone during the pandemic, and it is so much easier than having to actually go into an office for it.
Yeah, I would agree with that too. Because it's like
our lives have changed so much, but there thankfully have been some bright lights throughout this thing, and maybe we have found new ways to go about doing things, and to be able. And my sister, she had COVID symptoms, and she was able to see her regular doctor through telehealth as well. So even just going to the doctor, your regular practitioner, some of those appointments can now be done virtually. So we have learned so much, and I'm glad that you were able to do that over the phone. That's awesome. Any other comments or questions? What are you feeling as students and as professors and as people out in the world that are living your lives, and what's changed? How has this impacted just your mental health status? Do you feel like you've had have you experienced any episodes where you feel like, wow, maybe I should reach out, or maybe you just reach out to a friend or a family member? I know my daughter, she's young, she's a college student, and she's been learning from home, and I know she's so bored of being around us and not being around friends. And I really feel for her. I do. It's just been such a different time.
There's a statement from someone. It says, I have family members that are abusing substances. So how can I get them to get help they need to recover?
Well, first off, I'm sorry. That's a extremely stressful thing to watch people that you love basically kind of engage in this really self-destructive and really kind of scary like behavior. So I'm sorry that that's something that you're going through. And in terms of kind of motivating treatment, takes time. It takes a lot of those like conversations like, hey, you kind of can do it in a couple different ways. You can say like, I love you. I don't want to see anything bad happen to you. You mean a lot to me. But if you keep doing this, then you're not going to be able to be a part of my life, either because you spend all your time outside of your body feeling high, or you're actually going to do enough that it might even end your life. So I would suggest trying to kind of play along those lines, being a little sympathetic, adding a little bit of truth about how it's touching you, how you're experiencing it, and then kind of end it with that last truth. Like, this is a very real thing that you're engaging in, and there's a lot of risks to this, and I don't want you to risk it. I wish that you would kind of seek out those treatments, even just for yourself. And it is unfortunate, but you cannot make somebody engage in treatment. They do have to do it kind of at their own time, at their own pace. But having that conversation with them, being honest, can really kind of give someone that a little bit of perspective. And also, you could just say, you give it a shot, give it a try. Like, you could try it maybe give it like 3 sessions, see what happens. Sometimes that's enough. It's not too much of a commitment for somebody. And at the end, we have some like resources, like there's some phone numbers that you can call that the health department has. That's 24/7. You can talk to a therapist, you can talk to a peer support specialist, which is somebody that's in recovery themselves. And also you can talk to a nurse practitioner. So we have a lot of different resources. So it might even just be a matter of them having a conversation with someone with that profession, with that background.
We also, sorry, Jen. We have another statement. Personally, when the pandemic first started, my mental health declined drastically, especially as my senior year came to a sudden stop.
That's awful.
There's also an additional statement. Not being able to see friends before college really hit me hard. The last time I saw some of these friends was last summer, and I've been having trouble keeping in touch.
Yeah. Yeah, I feel for you there. It's like, this pandemic has disrupted, so much. And yeah, it's when you are used to, to so much supports from friends and family, and you suddenly don't have that, it's definitely going to take a toll.
But it's also important to talk about, and I'm glad that you're kind of able to say that, this actually was really hard for me. And I think sometimes, especially in a pandemic, we might minimize what we're going through because we know other people might be going through something worse. But everyone's feelings are valid. Everyone's feelings are just as important as somebody else. If you're struggling with something, it's worth talking about. So I'm glad that you shared that.
We have another statement. When the pandemic began, it made me realize how much initiative that I had through collaborating with friends in school. Being able to push each other made me thrive, but lacking that has been interesting to find a way to combat extreme procrastination.
Yeah. Well, actually, having that support network, that is a huge, great, wonderful coping skill. And you're right that like the pandemic really did kind of take that like ready, available like support group that you had away. So that it is really unfortunate. And now we're kind of like left to really try to find a support group, really kind of try to reach out, opposed to like when class is over, everyone gets up and you have a chance to kind of like debrief or just kind of like decompress with everybody. Now with like Zoom classes, you don't have that. You really kind of have to kind of go out of your way. And it's definitely a different thing that we've all had to adapt to, and it's hard. It's not what it once was.
And that seems to be it for the comments and questions in the chat now.
Okay, well, we'll go on to the next part. And we're getting ready, to talk about some pretty triggering things, domestic violence, intimate partner violence, child abuse. So if anyone, is worried that that might really disturb them, then I welcome you, to take a break, to, not watch it or whatever you have to do. So that's what we're getting into. Okay. All right. So domestic violence. And with domestic violence, there's been a lot of new challenges for survivors. One part of domestic violence is called intimate partner violence. It's serious, preventable public health problem that affects millions of Americans. It describes physical violence, sexual violence, stalking, psychological harm by a current or former partner. And it can occur, with same-sex couples or heterosexual couples, and it doesn't require sexual intimacy. Maintaining safety while living with an abusive partner is difficult under the best circumstances, but with COVID, it caused many people, to telework and to practice social distancing, and victims may find themselves confined at home with their abuser for extended periods of time. And here I just wanted to present a short video.
Unbelievable moment during an assault case that was being heard over Zoom. An attorney who thought the alleged victim was acting strangely asked a few questions, and it turned out the man accused of assaulting her was right there in the same apartment. Here's what happened next.
And I'm extremely scared for her safety.
It's the latest bizarre courtroom Zoom. A sharp-eyed prosecutor noticed something was off with this hearing for a man accused of assaulting his girlfriend.
The fact that she's looking off to the side and he's moving around. I want some confirmation that.
Veronica, could you increase the volume just a little bit? We're having trouble hearing.
The defendant, Kobe Harris, had been ordered to stay away from his alleged victim. They're on separate Zooms, but the prosecutor believes they're actually right near each other.
Your Honor, I have reason to believe that the defendant is in the same apartment as the complaining witness right now.
Miss Lindsay, where are you right now?
I'm at a house.
What's the address?
The defendant says he's at a different address, but the judge doesn't buy it.
All right, I want you to walk out to the front of the house, show me the house number on the house.
Police are called to the woman's home in Sturgis, Michigan. Turns out the suspicions are right. The defendant comes clean.
Your Honor, me and Mary both don't want the no contact.
The prosecutor rubs her face in disbelief.
I'm sorry I lied to you. I knew the cops were outside.
My advice is don't say anything else. Take the cigarette out of your mouth.
He's taken into
Here he
custody.
is.
Other memorable pandemic courtroom Zooms include the lawyer whose Zoom filter turned him into a cat.
I'm here live. I'm not a cat.
There was the surgeon who appeared on Zoom traffic court straight from the operating room.
Available for trial, go right ahead.
But there's nothing funny about a defendant sitting within inches of his alleged victim during his court hearing. Terry Austin is a legal analyst.
He's just making the case a whole lot harder for himself, this, defendant, because he's not cooperating. And so the judge very quickly put a stop to that.
And I'm extremely scared for her safety.
So additional abuse tactics, it includes, withholding, precautionary, supplies like hand sanitizer, or even withholding medical cards, sharing misinformation about COVID or preventing partners from seeking treatment, and then using the pandemic as an excuse for isolation. And then I have another video. It's a little longer. I might stop it a little early just so that we're good
It looks
on
like we only
time.
have like about 10 minutes left. Do you want to just try to?
Well, how about this? I'll just let you know. So this is the Battered Women's Justice Project. They did this video on coercive control during COVID-19. And it kind of shares, some tactics that they do and challenges that survivors are facing. All right. And then I'll put the website in the chat for anyone who wants to watch it. All right, so this is the power and control wheel. What certain agencies did is they interviewed, women who were in domestic violence situations, and they came up with this wheel to kind of show the different types of abuse. And so as you can see here, we have using coercion, intimidation, emotional abuse, using isolation, where you'll see a lot of times with victims is that they'll suddenly not really be around their family, or maybe they'll, they move out of the area. But that's a way for, the abusive partner to maintain control, of their victim. So, and then there's minimizing and blaming. A lot of you might have heard of gaslighting, which is where, they turn things around, to confuse their victim. They'll use children, and then they use, economic abuse, withholding money or taking their money, not letting them have access to it, not letting them have a job. And then there's also using male privilege, where maybe they treat their partner like a servant. They, want to make all the big decisions. They're not, collaborative. They're acting like a master. And they are big in defining men and female roles. This is kind of the cycle of violence. And what it is what you'll see is tension building. Then you have acute explosion. So that's where there's the issue. There's hitting, there's, acts of violence, verbal abuse, destroying property. Sometimes, police are called, or a neighbor calls the police. The victim might try to calm the batterer. Sometimes they fight back, sometimes they leave. Then there's the honeymoon phase, where things get better. Maybe they, the batterer might beg for forgiveness. They'll never do it again. They might bring in family support. There's, presence. And then at the center of it, there's a lot of denial. They don't, or they don't realize, they're kind of in this cycle, or they don't know how to get out. So during COVID, there's, some additional obstacles when leaving. A lot of times survivors, they make a safety plan in order to get out. But there might be a fear, right, during COVID of using shelters or going to a hospital. Courthouses were closed for a lot of the pandemic. Well, maybe not a lot, but in the beginning they did close down, and then they moved to telehealth. And then public transportation might be, an additional stressor, things that might complicate, someone getting out because of a relationship. And then also shelters being full or quarantined. So especially if there was like an outbreak in a shelter. Child abuse, again, it was a problem, anyway. And then now all the kids are at home, and there aren't a lot of, with school being online, there weren't the same types of interventions that could have been done as if there were in school. And, rates of child abuse before all of this, it costs, the country approximately 428 billion. That was in 2015. I'd hate to, to see what it is for this year, or 2020. And then, so again, their children are specifically vulnerable to abuse and COVID-19. Anytime, so what we do know with child abuse is anytime there's an increased stress level with the parents, it's a major predictor of physical abuse or neglect of children. And stressed parents are more likely to respond, to children's anxious behaviors or demands in aggressive or abusive ways. Also, there may be, support systems that are, that parents rely on, such as extended family, childcare, schools, religious groups, and those were no longer available during the pandemic. Child protective agencies are strained, with fewer workers available. Maybe they were unable to conduct home visits. And then again, since children weren't going to school, there were fewer, eyes on the children. There were fewer teachers, staff, counselors that were unable to witness any potential signs of abuse. And then many at-risk families don't have access, to the technology that children need to stay connected.
Hey, Veronica, it looks like we only have so many minutes left. If you don't mind just cutting down to the end where we go over kind of what Calvert Behavioral Health, where we are and what our hours are.
Sure. So those are just different coping skills. And then here's our...
So here's some of our services that we do. Behavioral health assessments is essentially how they all start. We can offer individual, group therapy, family therapy, substance use treatment. We can even refer out to if someone needs inpatient treatment. And this also kind of goes into a little bit of where we are. We're in the schools or in the jails or in the courts. We have peer support. We have people in our hospitals. That's what our Project Phoenix is about. And something else that I really want to touch on is our mobile crisis team. I touched on a little bit about that with one of the questions, but basically what that is, it's a 24/7 service. It's kind of like an ambulance for behavioral health and substance use issues, so mental health and substance use. And so I think if you go on to the next slide, it provides that. I think I wrote down the number if you want to call. Yeah, so that's what that substance use crisis response, that's at that mobile crisis, our MCT team. You can call them at any time if you have any substance use issues, or even if you have a loved one with substance use issues and you're kind of just looking for some resources. Also in this slide, you can see that some of our clinics where our addresses are. So we have location Prince Frederick, Barstow, Chesapeake Beach, Lusby. We're a little bit all over the county. Listed our hours, and I also have in here our walk-in hours. Basically, you can come in at those times and get enrolled in services. You can have access to a therapist and kind of talk about what it is going on in your life right then and what it is that you may or may not need. Anytime within those, within that time frame, open for you. Okay, so it looks like we kind of ran through the last part there. We talked more than I thought we would, but it does seem like we are wrapping it up. Let's say if anyone has any questions or anything, I guess we can check those out our way now.
I have one question, and that is, some of our students may be from St. Mary's County, from Charles County. Do they have similar, opportunities in those counties as we do in Calvert? And can students from other counties come to Calvert and use the resources here, or is it for Calvert County residents only?
Anybody from any county can come to Calvert Behavioral Health. We accept Medicaid as well as private insurance, as well as TRICARE. If you are in a situation where you don't have insurance, we just ask that you bring in some pay stubs, and then we can kind of work with you in terms of how you pay for services. I can say in St. Mary's County, the places to go for substance use would be Walden and Pyramid. They kind of have the cornerstone in that area. In terms of Charles County, the Charles County Health Department is very similar to Calvert in that they are a little bit everywhere and they do a bunch of different things. I can't speak exactly to what they can and can't do, but that if you're in those areas, those would probably be the best places to go.
Perfect. Well, we have reached the end of our time, and I just wanted to thank Casey and Veronica for coming and sharing with us today, your expertise, so much good information here. Thank you to our audience members for attending. We have 6 more events in the series. One is at 1 o'clock this afternoon, one tonight at 7. Pre-register and join us for those. And just I want to say, take care, everyone. Take care of yourselves. Take care of your physical health. Take care of your mental health. And don't be reluctant to reach out to these amazing resources that are there for you. Everybody take care, and thanks again.